Hello everyone. In this class, we'll study about parathyroid glands. Parathyroid glands, they are present on the posterior aspect of the thyroid gland. And parathormone secreted by parathyroid gland is essential for maintenance of blood calcium level. Calcium metabolism. Calcium is essential for bone formation, neuromuscular activity, normal cardiac rhythmicity, for coagulation of blood, formation of milk, mediation of intercellular action of hormones, fetal development during pregnancy, membrane integrity and permeability. Normal calcium level is around 9 to 11 milligrams per deciliter. The calcium is present in the different forms. The calcium in plasma exists in diffusible and non-diffusible forms. Diffusible calcium is in the form of ionic calcium is about 50% or complexed with bicarbonate ions, citrate ions, etc. about 10%. Ionized calcium is required for muscle contraction, it is required for cardiac activity and blood coagulation. Whereas non-diffusible, which is bound with albumin or globulin, is about 40%. Calcium in bone exists in two types. It is readily exchangeable form as a 1% and stable calcium almost 99%, which can be mobilized only through the action of parathormone. Regulation of blood calcium levels. Calcium is taken through dietary sources or absorbed from GI tract. Through blood, it is distributed to various parts of the body. Depending on the blood level, the calcium is either deposited or removed from the bone. All these processes are finally regulated by three hormones. That is mainly the parathormone. Second one is 1,25-dihydroxycholecalciferol, and third one is calcitonin. In addition to above mentioned three hormones, growth hormone and glucocorticoids also regulate blood calcium level. Growth hormone increases blood calcium level by increasing intestinal calcium absorption. Glucocorticoids decreases blood calcium level by inhibiting intestinal absorption and increasing renal excretion of calcium. Coming to parathormone, PTH or parathormone controls extracellular calcium and phosphate concentration. Parathormone increases reabsorption of calcium from the bones. It also helps in reabsorption of calcium from renal tubules. It also helps in absorption of calcium from GI tract. If you see the actions of the parathormone, their effect on the bones, the parathormone increases plasma calcium and decreases plasma phosphate concentration by promoting bone resorption. That is, it has an osteolytic effect. And it occurs in two phases, that is rapid phase and slow phase. In rapid phase, it is seen with few minutes of administration of parathormone. Plasma calcium is raised by increasing the permeability of the osteoclast, osteoblast, and osteocytes to calcium. And it increases calcium pump mechanism, allowing calcium ions to move from these cells to plasma. In slow phase, where it occurs in hours or days after parathormone administration, there occurs increased osteoclastic activity. Osteoclasts are large phagocytic multinucleated cells formed in the bone marrow. When osteoblasts are activated by parathormone, some osteo or proteolytic enzymes and several acids like citric acid and lactic acid are released. The enzymes digest or dissolve the organic matrix of the bone, and acid dissolves the bone salts. Eventually, the calcium ions are released into plasma. Along with calcium absorption, parathormone also increases phosphate reabsorption from the bones. The effect on the kidney. The PTH increases the reabsorption of calcium mainly from the distal tubules, collecting tubules, and to a lesser extent from the ascending loop of Henle. It decreases phosphate reabsorption. Reabsorption of magnesium and H plus ions are increased, while reabsorption of sodium, potassium ions, and amino acids are decreased. The effect of parathormone on intestine. It increases intestinal absorption of calcium and phosphates. Role of parathormone in activation of vitamin D. Vitamin D is essential for calcium absorption from intestine, but vitamin D has to be converted to 125 dihydrocholecalciferol, which is the active form. And these are some of the steps in activation. Initially, cholecalciferol, that is vitamin D3, is formed in the skin. Then cholecalciferol is converted into 25 hydroxy cholecalciferol in liver. Then 125 dihydroxycholecalciferol is formed in the kidney, and this step is under the control or supervision of parathormone. When blood calcium increases, it inhibits formation of 125 dihydroxy cholecalciferol. The mechanism involved is inhibition of formation of 125 dihydroxy cholecalciferol is calcium ion itself has a slight effect in preventing conversion of 25 dihydroxy cholecalciferol into 125 dihydroxy cholecalciferol. And increase in calcium ion concentration decreases the parathormone secretion, which in turn suppresses the conversion of 25 hydroxycholecalciferol to 125 dihydroxycholecalciferol. So this is how serum calcium levels are regulated. When serum blood calcium reduces, stimulates parathyroid to produce parathormone, which causes reabsorption of bone and release calcium. And the kidney is stimulated and it produces 125 dihydroxycholecalciferol, and also in the intestine it increases the absorption of the calcium, thus the blood calcium comes to the normal. When there is increased calcium level, there will be stimulation of the thyroid gland. Parafollicular cells produces calcitonin, it acts on bone, causes deposition of the calcium and reduces the calcium level. Actions of 125 dihydroxycholecalciferol: it promotes intestinal calcium absorption, it promotes intestinal phosphate absorption, it decreases excretion of calcium and phosphate from the kidney, and extreme quantities of vitamin D causes absorption of bone. In the absence of vitamin D, the effect of parathormone in causing bone absorption is greatly reduced. Vitamin D in smaller quantities promote bone calcification. So this is how metabolism of dehydrocholesterol occurs. It gets converted into cholecalciferol, which is inactive form of vitamin D3 under the sunlight, and this cholecalciferol it gets converted into 25 hydroxy cholecalciferol, and this this occurs in the liver, and this 25 dihydroxycholecalciferol gets converted into 125 dihydroxycholecalciferol, which is the active form of vitamin D3 in the kidney. This 125 dihydroxycholecalciferol increases the calcium absorption from the intestine and increases plasma calcium level. And this raised calcium level, by negative feedback mechanism, inhibits the formation of parathormone from the parathyroid glands. Regulation of parathyroid secretion: calcium concentration in the blood is a main factor, and increased phosphate stimulates parathormone secretion by lowering the plasma calcium and 125 dihydroxycholecalciferol. 125 dihydroxycholecalciferol acts directly to decrease pre-pro parathormone mRNA and decreases parathormone secretion. Magnesium deficiency causes impaired PTH release along with the diminished target organ responses to parathyroid hormone. Coming to calcitonin, calcitonin tends to decrease plasma calcium concentration and in general counteracts parathormone. You see its action on the bones, it facilitates the deposition of calcium on bones, suppresses the activity of the osteoclast, it inhibits the development of new osteoclasts in the bones. On the kidney, it is a minor effect, it increases the excretion of calcium through urine, and on intestine, again it's a minor effect, it prevents the absorption of calcium from intestine into the blood. Some of the applied aspects related: hypoparathyroidism. it is nothing but decreased secretion of parathyroid hormone, which leads to hypoparathyroidism. Some of the causes are surgical removal of the parathyroid gland, removal of the parathyroid glands during surgical removal of thyroid gland, deficiency of receptor for PTH in target cells. When total serum calcium level is decreased below 6 milligram percent, it results in hypocalcemic tetany. Simultaneously, serum phosphate is also decreased. The treatment for hypoparathyroidism is administration of 125 dihydrocholecalciferol, and sometimes there can be administration of parathormone, which usually not done. Tetany. Tetany refers to clinical condition resulting from increased neuromuscular excitability. When ECF concentration of calcium falls below normal, neuronal membrane permeability to sodium increases, allowing easy initiation of action potential. Some of the clinical features of tetany are carpopedal spasm, which is also called as obstetric hand. It's a peculiar attitude of hand in tetany. There is a flexion at the wrist and thumb with hyperextension of remaining fingers. There can be laryngeal stridor due to the spasm of laryngeal muscles. There can be visceral manifestations which include intestinal colic, biliary colic, and bronchospasm and profuse sweating. So this is obstetric hand in case of tetany. You can see the there will be flexion at the wrist joint, flexion at the metacarpophalangeal joints. There will be ECG changes like ST segment is prolonged with abnormal T waves. Trochiosinase, when occluding the blood supply to the limb by inflation of sphygmomanometer cuff, produces characteristic carpopedal spasm. And Chostek sign, when the tapping the facial nerve at the angle of jaw, produces ipsilateral contraction of the facial muscle, and this occurs due to the increased excitability of the nerves to the mechanical stimuli. Hyperparathyroidism. It occurs because of the increased secretion of parathyroid hormone. Based on the cause, it is divided into primary and secondary hyperparathyroidism. Primary hyperparathyroidism, where abnormality of the parathyroid causes excess PTH secretion. The cause is maybe a tumor of the parathyroid gland. Here, calcium ion concentration is elevated due to the extreme osteoclastic activity, and phosphate ion concentration is decreased due to the increased renal excretion of the phosphate. Secondary hyperparathyroidism, here high levels of parathyroid hormone occurs as compensation for hypocalcemia. The cause may be vitamin D deficiency or kidney damage. Some of the clinical features of secondary hyperparathyroidism are depression of central and peripheral nervous system, muscle weakness, constipation, abdominal pain, peptic ulcer, depressed relaxation of the heart during diastole. There can be increase in serum alkaline phosphatase levels. The cystic bone disease of hyperparathyroidism is also called as osteotic fibrosa cystic. Coming to the physiology of the bone. Bone is a special type of connective tissue with a collagen framework impregnated with calcium and phosphate salts, particularly hydroxyapatites. It is a living tissue that is well vascularized and has a total blood flow about 200 to 400 ml per minute in adult humans. The protein in bone matrix is mostly type 1 collagen. There are two different types of bone. One is compact bone or cortical bone. Another one is trabecular or spongy bone. Compact bone makes up the outer layer of the most bones, and it accounts for 80% of the bone in the body. Surface to volume ratio is low, and bone cells, that is osteocytes, lie in lacuna and they receive nutrients via Harvesian canals. Trabecular or spongy bone, it lies inside the cortical bone. They are made up of spicules or plates makes up remaining 20% of the bone in the body. Surface to volume ratio is high. Bone cells lie on the surface of plates. In spongy bone, nutrients diffuse from ECF into trabeculae. Bone growth. During fetal development, most of the bone are modeled in cartilage and then transferred into bone by ossification of endochondral bone formation. Certain bones, that is bones of skull, are formed directly from mesenchymal cells. It is also called as intramembranous bone formation. During growth, specialized areas at the end of each long bone, which are called as epiphyses, are separated from the shaft of bone by a plate of actively proliferating cartilage, the epiphyseal plate. The width of the epiphyseal plate is proportionate to the rate of growth and is affected by number of hormones like growth hormone and insulin like growth factor 1. And linear bone growth ceases after the epiphyses unite with the shaft, that which is called as epiphyseal closure. Bone formation and resorption. Bone is constantly being reabsorbed and reformed, which is under the cellular control of osteoblasts, osteocytes, and osteoclasts. The cells responsible for bone formation are osteoblasts, and the cells responsible for bone resorption are called as osteoclasts. Osteoblasts, they are bone forming cells, and they are found on the outer surface of the bones and in bone cavities. They synthesize and secrete collagen, forming a matrix around themselves, which then calcify to form a new bone. They have abundant alkaline phosphatase activity. Osteoclasts, they are phagocytic multinuclear giant cells containing numerous lysosomes. They erode and reabsorb previously formed bone. They contain several acids and appear to phagocytosize bone, digesting it in their cytoplasm. Osteocytes, they are bone cells surrounded by calcified matrix. Osteocytes remain in contact with one another and with osteoblasts via long protoplasmic processes that run through channels in the bone, forming the functional syncytium. Osteocytes provide rapid and transient movement of calcium from bone into the ECF space. Mechanism of formation of the bone. The initial stage in the bone production is secretion of collagen molecules, that is, which are called as collagen monomers, and ground substances that are proteoglycans by the osteoblast cells. The collagen monomers polymerize rapidly to form collagen fibers. The resultant tissue becomes osteoid. As the osteoid is formed, some of the osteoblasts become entrapped in osteoid. At this stage, they are called osteocytes. During the normal process of mineralization, minerals accumulate within the membrane-bound vesicles. Within a few days later or few days after osteoid is formed, calcium salts begin to precipitate on the surface of the collagen fibers. This process is controlled by parathormone, calcitonin, and 1,25-dihydroxycholecalciferol. Parathormone and calcitonin decreases the permeability of the bone cells to calcium, while 1,25-dihydroxycholecalciferol facilitates the active transport of calcium from osteoblast into extracellular fluid. In this way, calcium and phosphate concentration in the bone fluid is regulated. Osteoblasts secrete an alkaline phosphatase that hydrolyzes the phosphate esters, and the phosphate is released. Thus, whenever calcium phosphate ratio exceeds the solubility product, the calcium phosphate precipitates. Reabsorption of the bone. It is a process that involves destruction of entire matrix followed by removal of calcium. It is brought by osteoclasts. Osteoclasts, as we had discussed, they are phagocytic multinuclear cells formed in the bone marrow. When osteoclasts are activated by PTH, some proteolytic enzymes and several acids like citric acid, lactic acid are released, and enzymes digest or dissolve the organic matrix of the bone, and acids cause solution of the bone salts. All the dissolved materials are then released into the blood. So this diagram showing different cells like osteocytes, osteoclasts, and osteoblasts. Osteoblasts are bone forming cells, and osteoclasts are bone dissolving cells where they're going to increase the calcium levels. And osteocytes are the bone cells which through the canalicular system they help in the uh, in a contact between different cells and also with the different osteocytes. And and osteoblasts, these are the cells, which are able to maintain the concentration of the parathormone. uh, Under the influence of parathormone, they'll be able to increase the calcium levels in the osteoblast, and the calcium is pumped out of these osteoblasts, and the dihydrocholecalciferol also helps in the movement of calcium from the osteoblast cells, thus increasing the serum calcium levels. Some of the metabolic bone diseases like rickets. Rickets is a defective calcification of the bone matrix in children due to the calcium or phosphate deficiency caused by lack of vitamin D. Some of the causes are inadequate intake of provitamins and inadequate exposure to the sun, uh, sometimes kidney failure or liver failure or congenital hypophosphatemia, that is congenital reduced uptake of phosphate by the renal tubules, can lead to rickets. Some of the clinical features are there can be weakness and bowing of weight bearing bones, there can be thickening of the wrist and ankles, there will be retarded growth and shortness of stature, there will be dental defects, hypocalcemia, hypotonia, ricketic rosary, that is beading of costochondral junctions of the ribs, are characteristic features. In prolonged cases, usually signs of tetany also develop. Usually the treatment is done by supplying adequate amounts of calcium and phosphates in the diet and administration of vitamin D. Osteomalacia. Osteomalacia is the adult counterpart of rickets. Adults seldom have a dietary deficiency of vitamin D or a calcium, because large quantities of calcium are not needed for bone growth as in case of children. Some of the causes for uh, osteomalacia are steatorrhea, that is failure to reabsorb fat, so that vitamin D, which is a fat soluble, is not reabsorbed or absorbed. Or it can be because of congenital hypophosphatemia. Usually the complications of tetany are not seen in adults. Vitamin D resistant rickets due to the congenital hypophosphatemia, that is congenital reduced reabsorption of phosphates by renal tubules, must be treated with phosphate compounds instead of calcium and vitamin D. Renal rickets, it's a type of osteomalacia that results from prolonged kidney damage. The cause of this condition is mainly failure of the damaged kidneys to form 1,25 dihydroxycholecalciferol. Osteoporosis is nothing but decreased bone matrix, and usually it occurs in old age. Some of the causes for osteoporosis are lack of physical stress on the bones, malnutrition, lack of vitamin C, which is essential for secretion of intracellular substances, and lack of estrogen secretion. Estrogen decreases the number and activity of osteoclast. The old age Cushing syndrome, here the osteoblastic activity as well as deposition of protein in the bone is reduced. All these factors, they're going to lead to osteoporosis. So these are some of the points of the calcium metabolism and of parathyroid gland. Thank you.